So what is mental illness? So mental illness is a term that collectively refers to all mental health disorders, which can be health conditions characterized by alterations in a person's thinking and their mood, their behavior, and that's associated with some sort of distress or impaired functioning. So the person is having trouble doing something in their lives, like going to school, going to work, maintaining relationships. People with mental illness can experience things like a distorted view of their self, inability to maintain relationships, thought patterns or behavior patterns that impair their functioning and cause distress, impaired judgment, lack of insight about the person's own abilities, and consequences of their actions. So the etiology of mental illness in children is basically the same as adults. It's multifactorial. So one of the influences is genetics. So multiple genes have been identified that interact with environmental factors and seem to increase the risk for mental illness and some disorders. No single gene has really been pinpointed as causing mental illness, like in general, but certain genes have been identified with some disorders that we're going to talk about, like depression, anxiety, schizophrenia, bipolar, ADHD, and even bedwetting. So if a person has, say, a parent or a sibling that has a mental illness, it does increase their risk for developing a mental illness themselves. There's also psychological influences. So that can be things like stressful life events that the child has been through, the child's personality or temperament. So how do they react to certain situations, or how resilient are they to stress? Their gender. So some disorders affect males and females disproportionately. Like ADHD is usually more common in boys, depression more common in girls, things like that. And their age or developmental level. So children are going to respond differently to things like stressful events in their lives, according to how developmentally mature they are. And then social or environmental influences. So things like, do they have supportive parents or neglectful parents? Do they have a support group of friends, or do they have few or no friends? What's their socioeconomic status? Do they have risk factors for developing psychiatric disorders? Do they have access to mental health treatment if needed? Also, what is their culture and religion? So does whatever culture and religion that they are, sometimes that can be a barrier or a protective factor. So sometimes a person's specific culture may look down upon mental illness, same with religion, or it can be protective and a source of support for the person. And then what is their relationships with basically anyone in their lives? So their parents, their friends, caregivers, teachers, basically anyone. And of course, neurochemical influences, which can be things like neurotransmitters, things like dopamine, serotonin, cortisol that we can't outwardly necessarily test for in a person's brain, but have been shown to play a part in many of these mental illnesses. Trends in pediatric mental health. So 1 in 5 adolescents is said to have a diagnosable disorder, but many are undiagnosed or undertreated. Things like ADHD and autism are having higher prevalence rates in the last, say, 10 years. So is that because people are, having these disorders more often, or are we just recognizing them more frequently now and getting them the treatment they need? Also, pediatric caregivers, or I should say pediatric providers or pediatricians, sometimes lack the expertise or knowledge to treat children with mental health disorders. But the problem with that is that there's a lack of mental health providers specifically for children. So sometimes there are enormously long waits to get in with a provider because there are simply not any available. Assessment-wise, we can do mental status examination. So just as you would for an adult, there are certain ones that are modified for children. We're not going to be specifically going over those. So settings of care, therapeutic approaches in schools. So there's a variety of settings of care that a child can get therapy at or from. So school counselor could be an option, a therapist that comes to the child's home, outpatient psychiatrist or psychologist, group homes, residential treatment homes, intensive outpatient programs, and then of course inpatient psychiatric units. So inpatient psychiatric units are basically reserved for children who may be at immediate risk of harming themselves or others. So of course it could mean that they are suicidal, but it could also mean that maybe they're exhibiting behaviors that are just dangerous to themselves and that they may not realize. So if you think of someone who is maybe bipolar and they're having a manic episode, and they're engaging in risky behaviors that could lead to them harming themselves, but maybe not intentional harm. Can also be, of course, children who are exhibiting symptoms that are very severe at this moment in time. If you can think of people sort of like relapsing on their condition. So maybe they have schizophrenia and right now they're having a really hard time with it and they need hospitalization. It can be for a range of reasons, but of course it's usually for more severe conditions or at least times in the person's life. As with adults, it can be either voluntary or involuntary admission to inpatient psych. Although for children, I'm sure it's a little less likely for it to be voluntary unless it's an older adolescent. But it could also be, of course, involuntary, where the child is basically forced to go either by the court, possibly by a physician, or because of some sort of court ruling. Therapeutic approaches. So we already talked about play therapy, where the therapist can basically use the child engaging in play as a tool to learn more about the child. The child can describe possibly like an event that they've been through using toys or dolls. Similarly to that, art therapy and music therapy, pet therapy, and then things that are more in line with adult therapy, cognitive behavioral therapy, and dialectical behavior therapy, which are more intense, structured therapies that can help children learn what behaviors they may be engaging in that are maladaptive and try to replace those behaviors with more adaptive behaviors. So learning disabilities and behavioral challenges. So learning disabilities, it's kind of hard to think of it as like a mental illness, and it's sort of on a different level here, but it sometimes goes along with some of the things we're going to talk about. So learning disabilities is some sort of neurologically based problem where the person isn't able to learn basic skills normally, like reading, writing, or math. It can also interfere with higher level skills like abstract reasoning, time planning, or organization, long and short term memory and attention. So learning disabilities are more common in boys, and about 1/3 of these individuals also have comorbid conditions like ADHD or autism. Some things that can, or factors that can be involved in a child acquiring a learning disability can be things like, was there maternal drug, alcohol, or nicotine use? Genetics can also play a role and it can run in families. Environmental factors, like what is their school environment like? And then, of course, these comorbid conditions. Behavior problems, sort of going along with sometimes learning disabilities, can be things like, is the child acting out sort of excessively? undesirable behaviors that persist. So of course, all children are not perfect and show some behavior problems, but these are ones that are sort of extreme and persist over time. So things like throwing tantrums, throwing objects, um, cussing, stealing, um, engaging in fights, refusing to go to school or refusing to do their schoolwork, disrupting like class, for example, um, ignoring self-care for themselves and things like that. Again, some sort of normal behaviors for children that they learn to not do over time, but these are going to persist for some of these children. Stress in children. So stress is a normal part of life. Children and adults need to experience some low levels of stress in order to basically practice coping skills that can get them ready for future stressors that may be more severe. However, we don't want children to be under high levels of stress or things that can predispose them to maybe health conditions or mental health conditions. They may be predisposed because children just aren't developmentally mature. So they don't have cognitive maturity. They may have a lack of judgment. And depending on these different stressors that are going on in their lives, things like, are their parents getting divorced, or are they getting bullied? Are they moving to a different state? Things that could be possibly excessively stressful for some children, depending on the situation and possibly their own personality. Children can manifest stress in some of the same ways as adults, but also some other sort of vague ways that may be less noticeable that they're under excessive stress. So one of the big things is sometimes abdominal pain, or them saying they have a stomach ache for what seems like no reason. But things like stomach ache or GI upset or feeling nauseous or things like that can be a manifestation of stress, along with headaches, even bedwetting, being incontinent of stool, and having some of these behavior problems, like either acting inward, where they could be doing things like self-harming or overeating, or acting outward, where they're getting in fights or not paying attention in school or not listening to their teacher. Personality disorders. So personality disorders are pretty rare in childhood. However, there's some things we'll talk about, some sort of signs you can look for that may predispose them for developing a personality disorder as an adult. So personality is usually developed by age 2. So therefore, early childhood experiences, even before age 2, could influence whether a child will have a personality disorder as an adult. So if they went through some sort of traumatic experience or were separated from their parents, whatever it may be, could influence developing a personality disorder later in life. One of the precursors sort of to antisocial personality disorder is McDonald's triad. So triad because there's 3 things that we are going to look for. The first one is bedwetting or enuresis, also cruelty to animals, and pyromania or setting things on fire. So if a child has these 3 different things, they will likely have antisocial personality disorder as an adult. So if you come across a child that has bedwetting, and this doesn't mean like a 2-year-old that is wetting the bed because they haven't, fully got the grasp on potty training. This may be an older child where bedwetting is persisting, where we would expect the child to not be bedwetting because of their age. So if they are bedwetting, you may want to assess for these other things like cruelty to animals and pyromania, especially if they do have other sort of behavior problems going along with that. A personality disorder that can be diagnosed in adolescence or they can show signs of it that would later be diagnosed as an adult is borderline personality disorder. So with borderline personality disorder, it's usually adolescents. They can feel as though they're basically bordering between sanity and psychosis. They may exhibit certain behaviors, the big one being manipulation, or they can be trying to manipulate parents or friends, and in this case, basically nurses or staff if they are inpatient. So they can attempt staff splitting, where they're basically trying to make one staff member or several staff members think that other staff members are not providing the best care, and then doing the opposite when they see the other staff member. They can also be doing behaviors like self-mutilating behaviors like cutting, suicidal gestures or attempts. They can have frequent shifts in their mood, identity disturbances, inconsistency in their thoughts and their feelings. They may feel abandoned. They might have unstable relationships, and relationships that they do have could be overly intense. They can also have other cognitive dysfunctions like dissociations, disturbed thinking patterns, impaired problem solving, and impulsivity. So interventions for borderline personality disorder, and for a lot of these, first off, we want to make sure they're safe, so monitoring for suicidal ideation or attempts or gestures. Monitoring for any deliberate self-harm. Try to avoid manipulation and be aware that they may try to manipulate you. Establishing a routine and being consistent with that. Encouraging them to go to their group therapy, and administering medications if they are ordered. Impaired executive functioning. So this is sort of vague, not an actual disorder, but some patients with some of these mental health disorders can have impaired executive functioning. So these are basically the cognitive processes that help manage an individual's resources to achieve some sort of goal. So basically it involves mental control and self-regulation. So things that we need for higher level thinking, things like planning, sequencing, organizing, memory, and self-regulating emotions and behavior. So the components of executive functioning are things like complex problem solving, recalling things in their memory, controlling their emotions, and using language. So if the child has some symptoms of impaired executive functioning, they could exhibit symptoms like forgetfulness, a distorted sense of past events, an altered sense of time, self-awareness, and of the future. So some interventions for this is be concrete when we're talking to them or teaching them. We could use visual aids. Impaired executive functioning is partly related to things like ADHD. So things like reducing workload and giving extended time for tests. So that could be things like you may be familiar with, where a child gets extended time for tests, like double time or half time. Maybe they are allowed to turn in assignments late, like they have a time frame that they are allowed to turn them in late. Or maybe their assignments are sort of reduced a little bit so that they're not as intense, and they don't take maybe as much time. Also increasing support where they need support and supervising. Attachment disorders. So attachment disorders has to do with the quality of usually a parent-child relationship. It could be a caregiver-child, but for the most part, it's parent-child relationship. So attachment to the parent is biologically driven. So the child naturally just wants to be close to their parental figure, touch them, talk to them, interact with them. Both mothers and fathers, of course, play a role in this, but this disrupted attachment most often goes along with the mother. So this disruptive attachment occurs when usually an infant is unable to respond appropriately to a caregiver, or conversely, when a caregiver does not respond appropriately to an infant, or a combination of the two. So infants need a bunch of different basically cycles or expressions of a need, and then having the parent need, meet that need. So, like the infant cries because they're hungry, and the parent responds and gives them food. They need this to happen over and over again, and then basically they form an attachment. So, sort of like very simple. If they have some sort of disrupted attachment, it can result in things like feeding disorders, failure to thrive, the child having anxiety, or an actual attachment disorder. So some signs of this could be that the child is avoiding or withdrawing from either the parent, or sometimes this could be even other social situations like friends or teachers. Are they avoiding caretakers? And do they not understand social boundaries? It can also sometimes go the other way, where the child is maybe excessively attached to the parent. So when we think about things like separation anxiety, perhaps the child is has an especially high amount of anxiety when the parent leaves. So, like, say the parent is dropping them off at school for the first time. We would expect that the child maybe cries and, tries to grab the mother or the father or whoever is there. And maybe this happens for the first couple days or the first week, but then the child gets used to it and they go to school and it's not a big deal every day. But in this sort of attachment disorder realm, the child would do that literally every single day for the entire school year. There's also the primal wound theory of attachment disorders. So this is basically like a theory that says, why does this happen? So sometimes this happens when a child is separated from his or her mother at birth. So separation for whatever reason, possibly the mother dies in childbirth. Maybe they're separated because of a NICU stay. Maybe they're separated because the mother just basically has like a drug problem and leaves. It doesn't matter really what the problem is, but they're separated from some sort of for some sort of reason. So the child basically suffers from a sense of losing oneself, because from the child's perspective as an infant, they basically think that the mother and themselves are one being, until they sort of learn that they aren't as time goes on. So this is very hard to overcome even years later, according to this primal wound theory of attachment disorders. Of course, it's a theory. Treatment for this disorder in either infancy or early childhood is first basically assessing the behaviors of the child towards the caregiver. So are they having some of these behaviors like avoiding them or withdrawing from them, or the opposite end where they're maybe like overly attached? Also a safety assessment, and sort of different than like seeing, does the child's home have, those locks on the cabinets, but a safety assessment to see if this child has gone through some sort of trauma, basically like being taken away from their mother or separated at birth, or whatever their trauma is that they endured that caused them to have a attachment disorder. Is their home now safe wherever they are? So even if they're in like foster care, is it a safe place for them? Having someone who is emotionally available attachment figure. So if the parents aren't present, or the mother or the father, is there someone that can be emotionally available that's there basically all the time for the child? So can they stay in one foster home? Can they be adopted? Do they have like a sibling even that is there with them, that they can have somebody to basically attach to, if that makes sense? Sometimes early on, we want to limit contact with non-caregiving adults to avoid non-discriminant behavior. Basically, not having them be around a ton of different adults, and basically having them bond with whoever this emotionally available attachment figure is. Mood disorders. So this one should be fairly common to what you have learned before. So mood disorders are disturbances in a person's emotional state. that are going to affect their daily activities. So depression, anxiety, bipolar disorder. So depression's characterized by persistent sadness and a loss of interest in activities that they once enjoyed. And then bipolar disorder, those alternating periods of depression and mania. So depression is diagnosed in approximately 5% of US children and adolescents when they do have persistent sadness and a loss of interest, typically in fun activities that they enjoyed before. So things like hanging out with their friends, doing sports that they played, going to school if that was fun for them. Kids who experience some sort of stress or loss or have other comorbid disorders like learning disorders, conduct disorder, which we'll talk about, or anxiety disorders, have a higher risk for development of depression compared to other same age kids who don't have these issues. So mood disorder is an expression of depression that can manifest in a couple of different ways. So sad faces, which is on your slide, is sort of just a way to remember some of the manifestations of depression, which you probably already know them. But things like sleep disturbances, are they having trouble sleeping? Do they have an inability to experience pleasure? Do they have things like despair, fatigue, appetite changes, concentration problems, emotional sensitivity, or of course, suicidal ideation? So we always want to assess risk of suicide in someone who is admitted or who maybe has a history of depression to make sure that they are safe. They also could be doing things like acting out or having problems in school that aren't necessarily listed here. Again, bipolar disorder is an unusual shift in mood, energy, and activity levels, and the ability to think clearly. So they usually are going to fluctuate between mania, which is like a feeling of euphoria, and then their low mood of depression. And this is going to interfere with daily functioning. So there are the different types of bipolar disorder, type 1, type 2, and mixed episodes. You don't need to know the difference between those for our purposes. But remember, a manic episode is where a child or a person feels especially sort of high or euphoric. They have a lot of energy. They're not sleeping. They may be talking fast, have racing thoughts, very easily distracted, and they may engage in reckless behavior, which of course can be dangerous. So could be doing things that they wouldn't normally do that are dangerous, things like drugs, having unprotected sex, if they have money, spending money excessively. Nursing interventions, of course, assessing for suicidal ideations with both depression and bipolar disorder, making sure that the child's safe, helping them in any activities of daily living that they may not be able to perform because of excessive depression. And of course, administering things like mood stabilizing medications like lithium or antidepressant medications, or even antipsychotic medications in some instances. Anxiety disorders is also a mood disorder. So characterized by persistent excessive worry that interferes with daily activities. So these can also be, the feelings of worry can also be accompanied by physical symptoms, things like restlessness, irritability, concentration problems, insomnia, fatigue. Anxiety disorders are the most common psychiatric disorders diagnosed in children, including things like separation anxiety, which is common in young children. Also, things like test or school-related anxiety are common. So young children might not be able to verbalize their anxiety. They may not know how to basically express in words how they are feeling. So they can also have some of these vague physical symptoms like a headache or a stomach ache or nausea. With chronic anxiety, we want to decrease stimuli. So if they are in a room, like a hospital room, and a lot of things are beeping and the TV's on and the lights are super bright, we want to decrease all of those things. Give positive feedback when they do something that's good. Remain calm when around them. So if we are basically freaking out as nurses, that's not going to lower their anxiety. So we want to remain calm or at least appear calm. We can teach them relaxation techniques, things like deep breathing, journaling, whatever is relaxing for them, and encourage them to attempt to verbalize their feelings. Again, it can be hard for children because they just don't know how to express themselves yet verbally, in some ways to do with anxiety, but we can help them to try to express themselves. Obsessive compulsive disorder. So obsessive compulsive disorder is characterized by severe obsessions, which are basically recurring thoughts that are unwanted, and then compulsions, which are usually repetitive behaviors that interferes with the person's quality of life. So these obsessions or these recurring thoughts create anxiety, and the compulsions are performed to reduce the anxiety. So some of the common ones in children are things like hand washing, but can also be other forms of cleaning, checking things, counting things, ordering things, and even making confessions. So this is pretty rare in children. It affects about 2% of the child and adolescent population. There does seem to be a genetic component. And it does go along with some other disorders like autism and Tourette's. The child can also experience dissociations where they have a sort of dissociated sense of self or perception of self or the environment. So nursing interventions, the number one thing is we don't want to interrupt the ritual. So unless the ritual is causing them immediate harm to like their life or their body, we don't want to interrupt it. So if they're simply just hand washing, which yes, that can be sort of harmful over time. But if it's something simple like they're counting or whatever, we don't want to interrupt that ritual because this will make the child even more anxious and then want to continue the ritual even more. So we, or probably honestly more commonly a therapist, can instruct the child how to complete thought stopping, which is where we can teach the child to become more aware of their thoughts and literally trying to just stop them before they even have them or before they start to do their compulsion. Also, things like relaxation techniques, because this is basically a form of anxiety, can help sometimes reduce these severe obsessions. Going along with anxiety disorders are phobias. So phobias are excessive anxiety brought on by exposure to some sort of specific feared object or situation, which leads to an avoidance behavior. So more than just being scared of something, but an intense sense of dread that is so intense that the individual will do anything necessary to avoid it. So common phobias in children are things like fear of the dark, spiders or other bugs, enclosed spaces, heights, and even sometimes social situations. The treatment for this is usually exposure therapy, which again is usually not something a nurse is going to be conducting, but where they very slowly expose the child or person to whatever their phobia is. Panic disorder, or basically panic attacks, is episodes of an overwhelming sense of dread and doom. So children often report a feeling of dizziness and faintness, increased heart rate, and sweating during these episodes. Attacks may be frequent, or they may just be during an isolated attack during some period of extreme stress. So interventions for panic attacks or panic disorder is if they're in the middle of a panic attack, make sure that you're staying with the child and reassuring them that you basically won't leave them. So doing the best that you can to like literally just sitting with them and staying with them. Trying to decrease stimuli in the room. If like walking around with them as a way to relax them, you could do that as long as it's safe. And then, of course, this is one of the instances where we will probably be administering some sort of PRN and anti-anxiety medication. Post-traumatic stress disorder, or PTSD. So children can also develop PTSD after a traumatic event. So the traumatic event could be literally anything and can include hospitalization. So experiencing any element that was present during the initial trauma, so like a smell, a sound, an article of clothing. So this could be for a child in the hospital, hearing like an IV beeping, or seeing someone in scrubs, or smelling the smells of a hospital, can trigger a flashback. So if the child is having a flashback, especially if it's an older child, we don't want to attempt to interact with the patient who is experiencing the flashback. So if we do interact with them, like talk with them or touch them, you could actually become part of the flashback, which could put you in physical danger. Now, of course, if the child's 5 years old, they may not be able to do much damage to you. But if we're talking about an adolescent who is the same size as us or larger, you could put yourself in danger. So interventions for this, they could be on medication. They're hopefully in some sort of therapy, but we can encourage them to express their feelings and provide them with medications after the flashback to reduce their anxiety. Dissociative disorders. So dissociative disorders are basically characterized by some sort of failure in the person's brain to integrate consciousness, memory, and their identity. This is usually observed for children who have unfortunately been the victims of some sort of horrific abuse. So pretty rare for children and also adults. It's sometimes described as them overusing a defense mechanism. So patients usually report periods of a loss of consciousness, for which they have no memory of anything. So for them, it's sort of like escaping their current reality. So they've endured some sort of trauma and they basically want to escape maybe their thoughts. Dissociating just in general is easy for children, so especially between the ages of 2 and 7, because they naturally use things like magical thinking and are very creative, commonly make up friends, like imaginary friends and situations. So it can be much easier for a child to dissociate than an adult. Different types of dissociative disorders. Dissociative amnesia is basically the inability to recall. So, like a conversation or an event that happened, they have no memory of it. Dissociative fugue is unexpected travel away from home. So basically the child sort of like wakes up and they are somewhere not at home or where they expected to be, and they have no memory of how they got there. Depersonalization disorder is a feeling of being detached from one's body. So frequently people may report that they have a feeling of basically viewing their body from above, sort of like they have no control over what's happening and they're viewing themselves from the outside of their own body. Dissociative identity disorder, that's the one that was formerly known as multiple personality disorder. They just sort of changed the name of it, which is basically having more than one personality that the person can change through. It's extremely rare. Then there's dissociative disorder not otherwise specified. So basically the person doesn't fit the diagnostic criteria for any of these others, but they do exhibit some symptoms that may go with some of them. Disruptive disorders in children. So these disorders are basically seen as disruptive. It's a disruptive behavior disorders that are characterized by persistent behavior problems. Children with these disorders can be at high risk for physical injury because of some impulsive behaviors and things like fighting. The first one is ADHD, or attention deficit hyperactivity disorder. Doesn't necessarily have to be disruptive, and a lot of times isn't disruptive, but the other two that we're going to talk about are. So ADHD is characterized by 3 core symptoms: inattention, hyperactivity, and impulsivity. So they're basically inappropriate for the child's developmental level and pervasive. So they can have symptoms at home and at school and with friends. There are subtypes of this, like there used to just be ADD without the hyperactivity, but they sort of an old term now. But basically that was where the child was predominantly inattentive. So they didn't really display the hyperactivity that's sort of goes along with the name ADHD. So they can present as basically predominantly hyperactive or predominantly inattentive, or combined of the two. So there's subtypes that you don't really need to know. But if you know someone that has ADHD and they're not hyperactive, that is possible. They're just predominantly inattentive. So children who are predominantly inattentive may appear to not be listening when spoken to. They might have difficulty following through with tasks, like completing schoolwork. They might frequently lose items that they need for their task, like for schoolwork, like losing their homework paper. They might be easily distractible and might be easily appear forgetful. Children who are predominantly hyperactive may be fidgety, squirmy. They may run or climb inappropriately, talking excessively or asking questions excessively, interrupting often, and have difficulty waiting. There's a wide range of symptoms, and these are just a few. Discipline can sometimes be an issue. Parents can sometimes have difficulty managing the disruptive behaviors. So they may have slow information processing and difficulty sequencing information, which can lead to problems with like their schoolwork and the inability to complete tasks. So nursing interventions for this, the big one is a structured routine. Also, they could be going to family therapy or counseling, or individual therapy or counseling. Providing emotional support, making sure that they have like extra time for assignments or tests, or extra help, maybe tutoring, what's ever needed for their specific situation. And they are also frequently on stimulants. So examples like what's on the slide, things like methylphenidate, Adderall, and Vyvanse. There's a bunch of different ones now. But these stimulants are believed to work by increasing dopamine levels in the brain. So for people with ADHD, these stimulant medications help boost their concentration and focus, but actually reduce hyperactive and impulsive behaviors. We just want to watch out for things like if the child is losing too much weight because it is a stimulant, and are they having insomnia from the stimulant. So we want to pay attention to their side effects, because of course, depending on how old the child is, we want the child to usually be gaining weight, so we don't want them usually losing weight. The other disruptive disorders, which these make a little bit more sense on being disruptive, at least in my own opinion, is oppositional defiant disorder, or ODD for short. So oppositional defiant disorder is a persistent pattern of disobedience, argumentativeness, angry outbursts, a low tolerance for frustration, and a tendency to blame others for their misfortunes. So this is like the child is having excessively bad behavior in some instances where they have remorse for the actions. So say they are basically acting out in class. Maybe they yell at their teacher. They would later feel actual remorse for this, and maybe they apologize. Conversely, conduct disorder, or CD for short, is similar, but maybe more serious violations of social norms. So more aggressive behaviors, destruction of property, cruelty to animals. So a little bit more violent and more serious violations. But conversely, this one, the child does not have a lack of empathy or remorse. So they don't feel bad about the behaviors that they do. They don't apologize. So that's sort of the difference. Oppositional defiant disorder is a little less severe, and the child who feels remorse, where conduct disorder is more severe and they don't feel remorse. Conduct disorder is another one that can lead to antisocial personality disorder as an adult, as if you remember, those patients with that disorder also lack empathy and remorse. Impulse control disorders. So impulse control disorders are characterized by an inability to resist or control urges to do something that might harm themselves or others. These usually tend to develop around late school age or adolescence, like 11 or 12 years old, so a little bit older children. One of those is kleptomania. So this is the failure to resist the urge to steal things. So before the child actually steals something, they feel this intense tension. And then after they steal whatever the thing is, they feel intense pleasure and relief. So basically, stealing whatever they're stealing causes them relief from this basically like anxiety or tension. Pyromania, sort of similar, but is setting fires. So similar to kleptomania, they have this intense feeling of tension before they set the fire. And then after they set the fire and they're basically watching whatever it is burn, they feel gratification and relief. But for both of these, they may hopefully be in some sort of psychotherapy. They could be on aversion therapy or behavior modification. Intermittent explosive disorder is where the child has several occurrences of a failure to resist aggressive impulses that result in basically fighting or some sort of destruction of property. And the aggression is out of proportion to the perceived precipitants. So whatever they're excessively aggressive about, it's sort of like over the top for the situation. So for this one, they can also be on antidepressants, antipsychotic medications, and hopefully in therapy. So schizophrenia, childhood or early onset schizophrenia is characterized by delusions or hallucinations, disorganized speech or behavior, and some kind of marked impairment in social or school functioning. Childhood schizophrenia is much rarer than later onset schizophrenia or adult schizophrenia. So it's still a chronic illness with periods of exacerbation and remission. Patients with this are going to need lifelong medication management and therapy. The causes of schizophrenia are multifactorial. Genetic influences, biochemical differences in the brain, particularly dopamine, increased stress levels or traumatic events, drug use, and then another hypothesis called fetal origins of adult diseases, where researchers think that the child may develop schizophrenia because of intrauterine conditions. Some related disorders are things like schizoaffective disorder, depression with psychotic features, mania with psychotic features. Basically, these other sort of mood disorders that sometimes have features like hallucinations and delusions in them. Patients with schizophrenia do have an increased risk for things like cardiovascular disorders, depression, and other mood disorders and dementia, substance abuse, smoking, and of course, an increased risk of suicide or self-harm. Symptoms of schizophrenia in children. So symptoms are similar to those in adults. Their affect may be inappropriate. They may lose interest or pleasure in activities they once liked. They might have sleep disturbances and disturbances in concentration and a lack of appetite. They can also have delays in social and cognitive functioning, language, motor skills, attention, and perceptual behaviors. They also have effects on thought processes and content. So they can have rapid thinking, tangential or circumstantial language, which is basically where the patient keeps talking and talking, but never reaches the goal or like the point of their conversation or what they're trying to get across. They may have excessive or irrelevant details. They may also get stuck on thoughts and have difficulty expressing their feelings. They can also, of course, have sensory and perceptual disturbances, which is hallucinations and delusions. So remember, hallucinations are sensory disturbances and delusions are perceptual disturbances. These are fixed false beliefs. Sometimes they can be seen as exaggerated defense mechanisms. It becomes a big problem when these delusions or hallucinations are command hallucinations or delusions, where they're telling the patient to do something, particularly if it's something that could be harmful to themselves or others. Treatments and side effects. So they're going to need to be on antipsychotic medications that work by blocking dopamine receptors in the synapses. These medications can cause a range of side effects that we need to look out for. Side effects like motor restlessness, muscle tone impairment, Parkinsonian-like symptoms like tremors, and involuntary muscle movements. Autism spectrum disorder. So autism spectrum disorder is sort of a newer term where the DSM-4 combined what used to be called autism and what used to be called Asperger's syndrome into one disorder that is a spectrum, meaning it ranges from very mild to very severe. Asperger's used to be more of the mild sort of version of autism. So autism is thought to have multiple causes, just like anything else, genetic, biochemical, and environmental factors. These children can have, again, a range of symptoms from mild to severe developmental impairment and things like social skills, communicating in language, expressing emotions and becoming attached to others, such as their parents or friends, and the presence of some stereotyped behaviors or activities. So some of these stereotype behaviors or activities are things like hand flapping, rocking back and forth. A lot of times these children are not talking by 1 year of age. They may not respond to their own name. They seem almost as if they have some sort of hearing problem, like they're unable to hear, but physically they can hear. They may have violent tantrums, other odd movements. They may not smile as we would expect them to. They may have poor eye contact, might prefer to be alone. One big sign is if the child, usually like a toddler or even an infant, is lining objects up in rows sort of obsessively. And they may have an unusual attachment to an object or objects. So the rate of autism has been increasing at rates from about 10 to 17% per year, and it's the fastest growing pediatric disability. There are screenings that typically take place at the pediatrician's office. So usually these deficits are apparent by about 18 months, and the child usually diagnosed before age 3. So at the pediatrician office, usually they give the parents some sort of form to fill out that asks different questions if the child is having any of these problems. So it's called the CHAT and the MCHAT, which is where it's the checklist of autism in toddlers, and the M is just for modified. I believe it's just a little bit shorter, but it's asking questions like, does your child not respond to their own name? Or how many words can they say, depending on how old they are, Are they speaking sentences yet? Do they have poor eye contact? Do they have these movements like hand flapping or rocking back and forth? Anything like that. So the parent just basically goes down this little checklist and answers these questions, and it's screening for if they are at risk for having autism. And if they score high on this, then they can do additional testing. Nursing interventions. So we want to refer the patient for early intervention. So basically meaning getting them started in therapies as early as possible to make their quality of life as good as possible. So things like play therapy, speech therapy, maybe even occupational therapy or physical therapy can help these children. Setting firm rules with structure, positive reinforcement, decreasing stimuli, and then social skills training. Some of these children also have what's called sensory processing disorder. You don't have to have autism to have sensory processing disorder. It's sort of its own disorder, but these kind of go hand in hand. So basically, these children are highly sensitive to any sensory stimuli. So noises seem very loud to them, lights seem super bright, touch seems harsher than what it may be. So sometimes these children may not want to wear certain clothing because they don't like it, how it feels touching their body. So sometimes like socks and shoes is a big one. And also just not liking to be in environments where it's very noisy or very bright. So for these types of kids, they may have some sort of like exposure therapy if they can tolerate that to build tolerance up to being in like noisy or louder environments. Eating disorders. So eating disorders such as anorexia, bulimia, and compulsive overeating. So eating disorders, especially anorexia, can be extremely serious and often fatal over time. Common eating disorders are the ones I just said, anorexia and bulimia. They're caused by, again, a complex interaction of genetic, biological, behavioral, psychological, and social factors. Adolescent females are have a higher incidence of eating disorders than males. So anorexia nervosa is basically self-starvation. The person is relentlessly pursuing thinness or to be skinny. They are very preoccupied with their own body image and being skinny. Even despite being maybe severely underweight, the person still thinks that he or she is overweight due to a distorted body image. To be diagnosed with this, the patient needs to drop to less than 85% of their ideal body weight. Some of these patients will go on to develop bulimia. The onset of anorexia is usually in adolescence, but it can occur at any age, and again is higher in females. We need to be aware of some of basically the side effects of anorexia, or complications, I guess you could say. Things like malnutrition, muscle wasting, and of course dehydration and electrolyte imbalances. So seeing if they have any sort of symptoms of like hypovolemic shock, like cardiac dysrhythmias, and even increased risk for infection. Bulimia nervosa is binge eating with or without purging. Purging meaning vomiting, also using laxatives, and can also mean even excessive exercising. Bulimia is generally less life-threatening than anorexia, and the children or the patient typically can be normal weight, sometimes even slightly overweight. So it may not be as obvious to other people that something is going on. They usually have a lot of secret behaviors and not as many outward signs, so it can occur sort of in secret for a long period of time. Some of the signs and symptoms can be things like sneaking food, making excuses to go to the bathroom after eating large amounts of food sort of out of nowhere, taking laxatives, being concerned with their body weight and image, and enamel on their teeth becoming damaged if they are engaging in vomiting. Also, you can see Russell's sign, teeth marks on their knuckles from self-induced vomiting. Compulsive overeating, sometimes also called binge eating disorder, is basically an addiction to food. So this one they have characterized by episodes of uncontrolled binging, but they don't purge. They'll continue to binge on food even after full, even after sort of like painfully or uncomfortably full. The person, again, doesn't purge after eating and often feels very guilty or depressed after the binge episode. Substance-related disorders. So obviously, children, usually adolescents, can have a substance-related disorder with any of these substances and obviously more that are listed here. So recurrent use of one or more of these substances that causes some sort of clinical and functional impairment, and such as health problems, an inability to go to school or work or do home responsibilities. So approximately 9.4 of U.S. youth experience a substance use disorder. And also we worry about, of course, drug overdose with some of these prescription drug abuses that has been happening more recently. We talked about childhood abuse a little bit in the last module, but we're going to talk about it again really quick. So some risk factors for childhood abuse are things like substance abuse, living in a high stress environment, having unstable relationships, and a lack of support. These things can be either the child or the parents. The reason that this is in this module is because victims of childhood abuse basically have a much greater risk for development of psychiatric disorders. Sexual abuse is any sort of sexual act that basically the child obviously doesn't consent for, and it's usually by a caregiver, family member, or some sort of loved one. Assessment, sort of like we talked about in the last module, physical abuse can show bruises and various stages of healing, bruises in areas that are usually covered by clothes, bruises or wounds that are in the shape of an object like a hand or a belt or a cord, bite marks, cigarette burns, and aggression or fear towards adults. Sexual abuse, again, bleeding of the genitals or pain in that region, STIs, enuresis, sexual acting out, and sleep difficulties and other somatic complaints. The other one that sort of goes more hand in hand when we're talking about mental illnesses is Munchausen syndrome by proxy. It's now actually called factitious disorder, but they're sort of used interchangeably. But this is where the caregiver, and it's usually the mother, attempts to make the child appear ill. So sometimes this happens when the child really does have maybe some sort of illness in the beginning, and for whatever reason, the mother or the caregiver wants to continue possibly the attention that they are getting from all the appointments and things like that, and they continue to make the child appear ill when maybe they have recovered from whatever their problem is. So they could be making excessive requests for testing, excessive appointments, referrals to different sort of disciplines that aren't needed. They could be frequently changing medical providers over a short period of time. So then maybe the medical providers aren't noticing that they are requesting all of these different types of things that may be not needed or sort of out of line. One of the things that you can try to do is place a camera in the room if admitted to monitor the caregiver's actions, because sometimes these caregivers will do things to like sort of intentionally harm the child or actually make them sick. So you may have heard about in the news before, it's not always necessarily with children, but caregivers like injecting like feces into the IV, things like that we need to monitor and make sure that they're not doing. Sometimes there are already cameras in the room, like up on the ceiling, but they're usually not on. So that would be the best case scenario so that the caregiver doesn't notice that you obviously are like wheeling a camera or whatever into the room, monitoring their actions. This last question, which of the following is an appropriate nursing intervention for a patient with OCD? So just go ahead and go to the next. The answer to this one was B. We basically do not want to interrupt the ritual at all because it's going to increase their anxiety even more. So we can instruct the child on how to complete thought stopping. Again, this is going to be usually done by a therapist or someone specially trained in this.